Hi there. This is the second segment of two segments on the endocrine system. In this second segment, we will pick up with the topics that are listed on the right-hand side of this slide. So we'll talk about the thyroid, the pancreas and diabetes, the ovaries, the testes, as well as endocrine disruptors. Your thyroid gland is an H-shaped or butterfly-shaped gland that's situated on the anterior aspect of your trachea. And you can palpate it with your fingers by touching your neck. And the thyroid gland has two lobes, a left lobe and a right lobe. And then there's an isthmus across the anterior aspect of the trachea that connects the two. The hormones secreted by the thyroid gland include thyroid hormones and calcitonin. I will focus on thyroid hormones, T3 and T4. Calcitonin plays a role in blood calcium homeostasis, and that topic is not covered in this lecture. The thyroid hormones are T3 and T4, and they are important in determining your basal metabolic rate. And by that, I mean the rate at which your cells manufacture ATP and use ATP. Almost every cell in your body has receptors for T3 and T4. They are called T3 and T4. Those are shorthands for triiodothyronine and tetraiodothyronine, where tri means 3 and tetra means 4. And this is referring to the number of atoms of iodine that occur in each of these molecules. This is an image showing you the histology of the thyroid gland. And there are two primary types of cells in the thyroid gland. There are follicular cells, and in cross-section they look roughly circular, but these follicular cells make up the walls of these three-dimensional structures called follicles that are roughly spherical. And inside these follicles, we have a substance called colloid. And colloid is sort of that solid pink material that's surrounded by the follicular cells shown here. And in that colloid is where we find T3 and T4. A second cell type found in thyroid tissue are the parafollicular cells, and those cells are responsible for secreting calcitonin, which we're not going to talk much about. In this image, we see a single follicular cell in yellow, and we see the colloid up above in pink. And one of the goals of this image is to teach us about the synthesis and storage of the thyroid hormones T3 and T4. So down below that follicular cell is a blood capillary, and we can see that these follicular cells are able to collect iodine. Iodine is a mineral. It is an element. It appears on the periodic table. These follicular cells collect iodine out of the blood, and of course that iodine came from our diet. And they collect iodine out of the blood and use it as a key ingredient for synthesizing new molecules of T3 and T4. Triiodothyronine and tetraiodothyronine. And then those molecules are stored as colloid. Colloid is a word that describes a physical property of something, where a substance is suspended in a particular form. The thyroid gland is, to my knowledge, the only endocrine structure that actually stores hormones and has them ready, has them on hand, so that they can be released at the appropriate time. Other endocrine glands manufacture and secrete their hormones at the same time. So as soon as those hormones are manufactured, they are released from the cell. And that's not the case with T3 and T4. The thyroid gland is able to manufacture these substances and store them in this colloid and then secrete them following stimulation by TSH, which was, as you recall from the previous segments, TSH is secreted by the anterior pituitary, and it's thyroid stimulating hormone that then stimulates the thyroid to secrete T3 and T4 into the blood. So there are many disorders of the thyroid gland. These are the three that we will cover, and perhaps they're the three most common. We'll talk about a simple goiter, hypothyroidism, and hyperthyroidism. So goiter, or more specifically a simple goiter, is characterized by a lack of dietary iodine. In response to not enough iodine in our blood, the thyroid gets larger. Those follicular cells are constantly grabbing iodine from the blood because it's a key ingredient in making T3 and T4. And when those follicular cells are unable to obtain enough iodine in the blood because there's not enough iodine in our diet, those follicular cells proliferate. They multiply because the thinking goes that there are more cells, then the thyroid gland is better able to grab whatever iodine might be passing by in the blood. And sources of dietary iodine, good sources, include food items that come from the sea, including seaweed, that's an alga, and sea animals like shrimp and crab and fish. And if a person does not obtain enough iodine in their diet, they could end up with a simple goiter. In the United States and many other countries, one tactic that successfully prevents goiter is by adding iodine to table salt. So when you just go and buy a container of table salt in the regular grocery store, not only is it sodium chloride, but it has iodine added to it. And just that little bit of salt that you add to your food is enough to give you enough iodine so that if you avoid seafood totally, you are very unlikely to develop a goiter. Fortunately, goiter is easily treated with iodine supplements. So here's an image of a woman who has a simple goiter. It's very obvious, right? I had a student recently, we had a conversation, and she shared with me that she grew up in Burma, and when she was a little girl, she noticed that many people had goiters, and she approached it with a child's mindset, like, what is that? How come some people have that big thing in their neck and other people don't? Fortunately, it's easily treated if we know what it is and how to treat it. Just a little bit of iodine in the diet will make this go away. And here's a visual representation that allows us to compare a normal size thyroid and a simple goiter. The second thyroid disorder that we'll talk about is hypothyroidism. So hypo means below. So somebody with hypothyroidism has an undersecretion of T3 and T4. And the symptoms of hypothyroidism, many of them are linked to our basal metabolism. So somebody might gain weight. Somebody might feel cold often. Somebody might feel very tired all the time. They might exhibit bradycardia or a very slow heart rate. They might have constipation, which is due to a reduced motility of the GI tract. So because all of the cells' basal metabolism is too low, it results in this set of symptoms. It is generally an easy thing to treat. We can supplement the thyroid hormones with synthetic thyroid hormones that must be taken on a daily basis. And then sort of the opposite of hypothyroidism is hyperthyroidism. Hyper means above. And so circulating levels of T3 and T4 are too high. And so this causes our cells' basal metabolism to run too fast. They're making and using ATP too quickly. And so this can lead to an intolerance to heat. They feel hot, they're sweaty all the time. Because of their increased basal metabolism, it means biochemical reactions are happening too fast and they're generating too much heat, and they constantly need to be shedding this heat, like by sweating, in order to maintain their normal body temperature. They might have diarrhea due to hypermobility of the GI tract. Things are moving too quickly. They might lose body fat or even body protein. So this weight loss is due for this high demand of fuel sources of calories to maintain this supply of ATP. They might have tachycardia, which is a higher than normal heart rate. And it extends over into the nervous system, where symptoms of hyperthyroidism include anxiety, nervousness, and even a shaking. It is a little more difficult to treat because now we have the situation where we have too much T3 and T4, and how do we bring those circulating levels down? So treatment might include drugs that inhibit the synthesis of thyroid hormones in the thyroid. It might include radioactive iodine therapy. And so this piece of radioactive iodine is implanted in the thyroid gland or delivered to the thyroid gland. It doesn't necessarily need to be implanted. The thyroid gland will take up iodine, regular or this radioactive isotope. And this radioactivity, this energy that these atoms give off, can kill follicular cells or kill any cells, but it's in the thyroid. And by killing off some of the thyroid cells, we're going to lower the rate of T3 and T4 synthesis. And then surgically, if we just take out part of the thyroid, that might solve the problem of too much T3 and T4. Our next endocrine gland is the pancreas. And we talked about the pancreas as part of the digestive system. It is. It is also part of the endocrine system. So your pancreas is two types of glands in one. As part of the digestive system, it's an exocrine gland. Certain cells in the pancreas manufacture the components of pancreatic juice and secrete those components into pancreatic ducts that lead into the small intestine. That's not what we're going to talk about in this endocrine lecture, but rather we're going to talk about the islet cells that manufacture hormones, including insulin and glucagon. And those hormones are secreted not into ducts, but rather those hormones are secreted into the extracellular fluid and they diffuse into the blood. So here we're looking at the stomach, the small intestine, and the pancreas. And there are two different types of cells in the pancreas. Let me start by pointing out the green system of ducts, right? Everything green there is a duct. And a duct is just a little tube that allows a liquid to travel through it. And so in the pancreas, the acinar cells, which are sort of in that gold color, the acinar cells are the cells that are responsible for secreting the components of pancreatic juice. So those pancreatic enzymes and the bicarbonate and the mucus. That's an exocrine function. And those blue arrows show the movements of the components of pancreatic juice from the pancreas into the duodenum. As part of the endocrine system, we need to talk about the islet cells. So they're called the islets of Langerhans, and the more modern name is pancreatic islets, because we are no longer naming things after people. So the pancreatic islet cells are sort of the lavender dots. And these are clumps of cells that are not associated with a duct. And these clumps of cells include cells that secrete insulin and other cells that secrete glucagon. So in this diagram, let me maybe use green because there's not a lot of green on this slide. So let's take a look at these cells are the acinar cells, right? And they're associated with a duct, and they make the components of pancreatic juice that make their way towards the small intestine. In the endocrine system, we are interested in these cells. This is a pancreatic islet, and it's made up of a couple of different cell types. And one type of cell, the alpha cells, make glucagon, and another type of cell, the beta cells, make insulin. And that's what we're seeing here. This is a beta cell. It's part of a pancreatic islet, and it's responsible for manufacturing and secreting insulin, which looks like these little yellow ovals. To me, they look a lot like bacteria, but that's not what's happening here. These are molecules, these things here. These are molecules of insulin, and insulin is a small protein hormone. It's a peptide hormone. And so this beta cell manufactures insulin and secretes it by exocytosis, and it diffuses into the blood. Remember, it actually has to cross the capillary wall by transcytosis. Okay, so once it's in the blood, that insulin travels all over our body, it gets out of our blood, and then it binds to receptors on our target tissues. This is what the pancreas looks like using a compound light microscope. So most of these cells out here, hopefully you can see that drawing. I'm sort of scribbling in green on the right side of that image. Most of those cells are the acini cells, and they are part of the digestive system. And this is a pancreatic islet here. And in that pancreatic islet, we find the alpha and beta cells, which secrete glucagon and insulin. So we'll spend quite a bit of time talking about blood glucose homeostasis, and we'll also talk about diabetes, which is a disorder that affects the body's ability to maintain blood glucose. So insulin is secreted by beta cells in the pancreas, and their insulin has several actions. And remember, the hormone's action is the specific way in which a target cell responds to that signaling molecule. So these are two major actions of insulin. So most of our body cells have receptors for insulin, and insulin will cause our body cells to become more permeable to glucose, and glucose will undergo facilitated diffusion and enter our body cells. And this is how insulin, one way in which insulin helps lower blood glucose. Another target for insulin is liver tissue. Hepatocytes have receptors for insulin, and those liver cells also become extra permeable to glucose, so they allow more glucose to come inside. And once that glucose is inside in the liver, that glucose is used to synthesize new molecules of glycogen. And glycogen is our body's way of storing glucose. Glycogen is a polysaccharide, and our liver cells make glycogen, and our skeletal muscle cells make glycogen. And so insulin helps maintain blood glucose levels after a meal. While that glucose is entering your blood from the GI tract, insulin acts as a regulator to help maintain or to help reduce blood glucose levels so it doesn't get too high. So there are lots of pieces to this homeostatic feedback mechanism, and we're going to start here. So homeostasis. Here's our target. Here's our set point for our physiologic variable, for our controlled condition. Our controlled condition is the concentration of glucose in the blood. And our set point is around, everybody's a little bit different, but let's just say the set point is 90 milligrams per deciliter. A deciliter is 100 milliliters. So if you're in the fasting state, it's been a long time since your last meal, and we take a sample of your blood and use a glucose meter, we should see a fasting blood glucose somewhere around 90 milligrams per deciliter. But then let's say you eat a meal, and that meal includes carbohydrates, as most everything does. Most meals contain carbohydrates. Those carbohydrates are going to be catabolized in your GI tract into monosaccharides, and those monosaccharides are going to be absorbed. Anything that's not already glucose, like fructose, will quickly be converted into glucose. And so during the absorption of carbohydrates across the GI tract, that causes your blood glucose to go up. And in this diagram here, that's a deviation from homeostasis. The receptor in this feedback system are those islet cells, the alpha and beta cells. Here we're interested in the beta cells. The beta cells are able to detect the amount of glucose that's in your blood, and they're constantly monitoring it. And when the beta cells detect that blood glucose has increased, they release insulin into the blood, and insulin is a signaling molecule. So we can continue this diagram by thinking about the actions of insulin. So most of our body cells have insulin receptors, and they all become more permeable to glucose. And that's one way that glucose in the blood is lowered, is when body cells collect that glucose. Another major target for insulin are our hepatocytes, our liver cells. Yes, our liver cells become more permeable to glucose, and our liver cells can store that glucose by forming new molecules of glycogen. So do your skeletal muscles. And so these two effectors, body cells, so you think muscle cells here, or other body cells as well, but muscle cells and liver cells are the two primary effectors in blood glucose homeostasis when the controlled condition has risen above the set point. In response to insulin, muscle cells, other body cells, and liver cells take up glucose out of the blood, and that causes blood glucose levels to decline, and that gets detected by the beta cells in the pancreas. The receptors are in the beta cells. The beta cells detect, oh, okay, blood glucose is back down to normal. We can stop secreting insulin now. So it's a negative feedback system. There's another half to this feedback system. The other half involves a hormone called glucagon. And glucagon is also secreted by your pancreas. It's also secreted by cells in the pancreatic islets, by alpha cells. Glucagon increases blood glucose levels. Well, how do we get more glucose into the blood? We perform glycogenolysis. That's the splitting of glycogen. And this happens in your liver, and your liver cells can release that resulting glucose into the blood. So glucagon helps maintain your blood glucose levels when you're in the fasting state or the post-absorptive state. You haven't eaten in a while. Your cells are constantly using glucose out of your blood. There's no glucose coming in across your GI tract. Where does that blood glucose come from? Well, under the influence of glucagon, your liver cells secrete glucose into your blood, and you're gradually depleting your liver supply of glycogen. So here's the other half of that homeostatic feedback mechanism. We're back at the homeostatic set point, which is a blood glucose of about 90 mg per deciliter. And then you haven't eaten in a while. There's no incoming glucose from the GI tract. Your cells keep using glucose to support cellular respiration. They're using glucose as a fuel source to make ATP. And so your blood glucose starts to fall. Well, you have these alpha cells in our pancreatic islets, and they are constantly monitoring, well, how much glucose is in the blood? How much now? How about now? What about now? Oh, it's starting to fall. Oh, okay. Then the alpha cells, in response to lower than normal blood glucose, they secrete glucagon into the blood. And glucagon is a signaling molecule. And the primary target of glucagon are hepatocytes, or liver cells. So glucagon is going to cause liver cells to perform glycogenolysis, the splitting apart of glycogen, and the resulting glucose is released into the blood, and that results in a higher blood glucose concentration. And so we've restored the physiological variable to the set point. It's a negative feedback system. The fact that blood glucose has returned to the normal range of about 90 mg per deciliter, that gets detected by those pancreatic islet cells, and glucagon secretion is shut off. And so in this diagram, we see two halves of blood glucose homeostasis. When blood glucose approaches its upper limit, then the pancreas releases insulin, and insulin helps to lower blood glucose. And when blood glucose starts to reach its lower normal limit, the pancreas releases glucagon, and glucagon helps increase the amount of glucose in the blood. And so these circuits are operating all day long. And remember that homeostasis operates as a constant shifting balance, a little more, a little less, a little higher, a little lower, 24/7. And in the case of blood glucose, it's mediated by these two pancreas hormones, insulin and glucagon. So this brings us to diabetes. Diabetes is by far the best known and most common endocrine disorder. It is caused by either a deficiency of insulin, the pancreas does not make enough insulin, or the cells are resistant to insulin, which means they don't respond to insulin normally. The insulin might be there, the insulin receptors might be there, but for complicated reasons and reasons that are still being researched, the cells do not become more permeable to glucose. And so diabetes is characterized by having higher than normal blood glucose levels, even in the fasting state. Glucoseuria, remember that term, it refers to the presence of glucose in urine, and that is not normal. And then ketosis. Ketosis occurs when the body is relying on non-carbohydrate fuel sources to make ATP. Specifically, the body is relying on fatty acids to make ATP. So there are 3 types of diabetes: type 1, type 2, and gestational. What's the difference between them? Type 1 diabetes develops when the immune system destroys the insulin-producing cells of the pancreas. So it can be viewed as an autoimmune disorder. So one of the major functions of the immune system is to be able to distinguish self from non-self. What are all the cells and molecules that belong in my body? And then what are the cells and molecules that don't belong in my body? And sometimes immune systems make mistakes. Sometimes immune systems mistakenly identify molecules that are legitimately self. Sometimes the immune system mistakes them for foreign molecules and brings about responses that end up killing the cells that have those foreign molecules, or quote, foreign molecules associated with them. So in people with type 1 diabetes, their immune system cells kill their pancreas cells that produce insulin. So they are left with few to no insulin-producing beta cells. And so type 1 diabetes, if it's going to develop in a person, it usually develops during childhood or young adulthood. However, it can develop at any age. And because it usually develops during childhood, it used to be known as juvenile onset diabetes. And these people are dependent on insulin for their lives. And so sometimes it's called insulin dependent. So for people who are dependent on insulin, some of them choose to use what's known as an insulin pump. So it's a wearable device, and in that pump that's clipped to her waistband, that pump includes a reservoir that holds insulin, and she can program it based on her current blood glucose level and what she has just recently eaten, or even better, what she's about to eat. She can think about the amount of carbohydrates that she's about to take in and tell that pump to administer a certain quantity of insulin. And that insulin travels through the catheter, that soft, flexible tube that is implanted subcutaneously. And so that insulin gets delivered into her subcutaneous fat and makes its way into her blood. And it's a signaling molecule, and she doesn't have insulin insensitivity. Her cells are perfectly sensitive to insulin. And so insulin acts the way insulin should, and her cells become more permeable to blood glucose, and they take up the glucose out of her blood. Type 2 diabetes is actually a much different disease, and it's much more common. The vast majority of people who have diabetes have type 2 diabetes. So at this point in the class, I ask students to raise your hand if you know or love someone with diabetes, and almost all the hands go up. And for all of those hands that go up, the vast majority of those hands go up because they know or love somebody with type 2 diabetes. It's far more common. And so in somebody with type 2 diabetes, it is not, as far as we know, there's no evidence that it's an autoimmune disorder, but rather it's a metabolic disorder. And it appears that type 2 diabetes begins with a condition known as insulin resistance, or pre-diabetes, which I'll talk about more soon. So insulin resistance refers to a situation where insulin is present, there are insulin receptors present, but for complex and not thoroughly understood reasons, our body cells are unable to respond to insulin in the normal way. There's something disrupting that signal transduction pathway. And so it means that our cells don't respond to insulin by becoming more permeable to glucose. And so in insulin resistance, blood glucose can become dangerously high, and simultaneously our cells are starved of carbohydrates. So type 2 diabetes used to be known as adult onset diabetes because it usually is diagnosed in adulthood or middle age. But increasingly over the years, over the decades, we are diagnosing type 2 diabetes in younger and younger people. And so anybody at any age can develop type 2 diabetes. It is more common for an adult than a child to develop type 2 diabetes. And then our third category of diabetes is gestational diabetes, where gestation refers to pregnancy. So gestational diabetes can only occur during pregnancy, and during pregnancy, mom's body has a difficult time regulating her blood glucose. Her cells exhibit signs of insulin resistance. This is actually an example in evolutionary biology. This is an example of what's known as parent-offspring conflict. So when we think about the interests, the biological interests of the parents, and that is to reproduce, to have a healthy baby, and then for the parent herself to stay healthy enough to have more babies, right? That's how natural selection works. And then if we think about the biological interests of the child, from the child's perspective, that child will have a higher likelihood of surviving and thriving if it's born at a healthy birth weight. And so certain signaling molecules that are released by the developing fetus and the placenta are thought to contribute to gestational diabetes. And these signaling molecules that originate from the pregnancy can raise mom's blood glucose, making more glucose available to the developing fetus, making it easier for that developing fetus to grow and to become large enough to be this healthy, thriving newborn. And so there's a conflict there. What's good for the baby is not necessarily good for the mother. So gestational diabetes may or may not require treatment. What does need to happen is she needs to monitor her blood glucose levels, and she might be able to control her blood glucose levels just with a combination of diet and exercise, or carbohydrate metabolism modifying drugs might be prescribed, or even insulin might be prescribed. So gestational diabetes is reversible. It tends to end as soon as the pregnancy is over. Her body goes back to being able to adequately control her blood glucose. However, in women who have gestational diabetes, they have a much higher chance, a 40 to 60% chance of developing type 2 diabetes over the next several years. So why is diabetes a problem? Why is it a threat to health? We can look at this through two lenses. There are short-term risks and long-term risks to having this uncontrolled or poorly controlled concentration of glucose in the blood. So let's think about the short-term risks. Health complications that can arise in a matter of hours with this uncontrolled amount of glucose in the blood. So having blood glucose that is either too high or too low can pretty quickly lead to a diabetic coma and death. Certain cell types in our body rely on glucose to make ATP. Our red blood cells can only use glycolysis to make ATP. They don't have any mitochondria. They can't use fatty acids. They can't use amino acids. There's no Krebs cycle. They have to rely on glycolysis to make ATP. And our neurons rely primarily on glucose. They can't easily shift to using amino acids or fatty acids. And then there are the long-term complications. It turns out that having a high blood glucose level over the years can lead to changes in blood pressure, and those changes in blood pressure can do incremental damage to capillary beds all over our body. And that incremental, a little bit here, a little bit there, those incremental changes add up and give rise to these long-term complications of uncontrolled or poorly controlled, poorly managed diabetes. And so when somebody has undiagnosed diabetes, it is common for them to exhibit these symptoms: excessive urination and excessive thirst. So they need to pee a lot and they feel thirsty all the time. So the water goes in, the water goes out. They can also feel excessively hungry. They can eat a lot and not necessarily gain weight. They might gain weight, they might lose weight. So how do we diagnose diabetes? Somebody who's suspected of being a diabetic is issued 2 different tests, a fasting glucose test and a glucose tolerance test. And so a fasting glucose test involves measuring blood glucose following an overnight fast. So you wake up in the morning, we take a little drop of your blood and apply it to a glucose meter, and we see, hopefully, that your fasting glucose is somewhere around 90 milligrams per deciliter. But it might be higher, it might be lower than that. And then there's a glucose tolerance test. How well does your body tolerate an influx of glucose? Think of it that way. So the person shows up at the medical office in the fasted state, right, in the post-absorptive state. They get their baseline fasting blood glucose read, and then they consume this really thick, like super sweet, sugary beverage. And then 2 hours after drinking this sugar bomb, is a way to think about it, we take their blood glucose again. And then if their insulin is working properly, then their blood glucose is below a certain level. And if their blood glucose is too high, it suggests that they have diabetes because they are unable to adequately control their blood glucose level. Then there's the condition of pre-diabetes. And check out that statistic in the bottom bullet point there. Currently, 34% of US adults, that's more than 1 in 3, a third of us, have evidence of pre-diabetes. So we are starting to lose control over our ability to regulate blood glucose. So blood glucose levels are higher than normal, but not high enough for a diagnosis of diabetes. That's 1/3 of us. The good news there is that if you're pre-diabetic, it does not necessarily mean that you will become diabetic, because just a little bit of exercise and a little bit of dietary control of carbohydrate intake can reverse pre-diabetes. And I mean a little bit of exercise. You don't have to go from having a sedentary lifestyle to going for a run every day. No. How about a 20-minute brisk walk 3 days a week? That might be enough to reverse somebody's pre-diabetic diagnosis into no longer being diagnosed with prediabetes. So when somebody has diabetes, how do we treat it? And this goes for all 3 forms of diabetes: type 1, type 2, and gestational. The overarching goal is to keep blood glucose levels within the normal range as often as possible. So now you, the human, have to do some of the work of your pancreas. In people who don't have diabetes, the pancreas takes care of your blood glucose level. In people who do have diabetes, you know what? You have to take care of your blood glucose level. And this rigorous control of your blood glucose levels will dramatically lower the risk of developing complications over time. My mother-in-law is a type 1 diabetic, and she was a very early adopter of an insulin pump. And she is now almost 80 years old, and she has had diabetes for decades. And she has no long-term complications because she has so vigorously controlled her blood glucose over the years. Okay, so how do we control our own blood glucose? This means watching what you put in your mouth. The carbohydrates that enter through your pie hole are going to be catabolized and absorbed into your blood. And so if you can reduce your dietary intake of carbohydrate, you can reduce the elevation in blood glucose following a meal. And then exercise. When your skeletal muscle cells are more active, they have a higher demand for glucose. They're going to use more glucose, and that will help to reduce blood sugar levels. And then weight control. we know that type 2 diabetes has something to do with the amount of fat that's in our bodies. And it is known as a metabolic disorder. And these metabolic disorders, a whole like umbrella of disorders. And we're still working really hard to try to understand them. What is it about adipose tissue that can hijack our body's ability to regulate the amount of sugar in the blood? We're not sure, but if you can reduce your adiposity is the term, if you can reduce the amount of fat on your body, that is a successful way to manage type 2 diabetes, to manage and to prevent actually type 2 diabetes. Depending on which type of diabetes you have or how severe it is, your physician may or may not ask you to check your blood glucose levels several times a day. Your physician may or may not prescribe insulin for you. Your physician may or may not prescribe drugs that can influence how our bodies use carbohydrates. One technology that's been in development for decades are islet transplantations. So in an islet transplantation, this is performed in order to treat and hopefully cure type 1 diabetes. So remember, in the type 1 diabetic, they lack functioning beta cells. Those beta cells are constantly being killed off by their immune system. So if they only had functioning beta cells, they would be cured of their type 1 diabetes. So most of us have functioning beta cells. So these beta cells, these pancreatic islet cells, are harvested from recently deceased people. And they are treated chemically and then injected into veins around the liver, specifically the hepatic portal vein. And our goal here is to get these donated islet cells to lodge in the liver tissue. It really doesn't matter where these islet cells are, as long as they're alive, they'll be able to detect blood glucose and release insulin in response to higher than normal blood glucose levels. And so in a successful islet transplant, these beta cells, these islet cells, go on and take up residence in the patient's liver. And they live, they thrive, they make insulin, and the person no longer has type 1 diabetes. This is still an uncommon treatment for type 1 diabetes. It's still in clinical trials, but phase 3 is pretty far along in the process. And we're hopeful that eventually it will be the most common treatment for type 1 diabetes because it does actually offer a cure. Another treatment for diabetes is what's known as an artificial pancreas. That's not really an accurate term. Your pancreas does a lot. And so to call this device an artificial pancreas is to hold it in too high esteem. Rather, what this device does is it can monitor your blood glucose constantly and release insulin when you need it. So it's sort of, as a type 1 diabetic, it will do your job for you. So instead of having to check your blood glucose several times a day and then determine how much insulin you need to deliver into your own body, this device will do that for you. So the CGM is a continuous glucose monitor that is implanted in the person's body. And so it's doing the job of the beta cell. It's constantly monitoring how much glucose is in the blood. And when that glucose starts to rise, it sends a signal to a device that calculates how much insulin is needed to be added to the blood to bring back glucose into the normal homeostatic range. All right, so what are those long-term complications of chronically undermanaged or poorly managed diabetes? These are the outcomes for people who either they don't know they have diabetes and so they're taking no action because they're unaware, or they know they have diabetes and the steps that they're taking to manage their blood glucose levels aren't enough. And these conditions don't result from a day or two, a year, where the blood glucose level gets really high. That's actually pretty well managed diabetes. But these complications result with chronically undermanaged. So it's just like, it's an exposure situation. So just think about tobacco and lung cancer. You know, maybe you smoked 2 cigarettes behind the shed with your cousin when you were 12, and those 2 cigarettes don't mean that you're going to get lung cancer. those 2 occasions where you let your blood glucose get too high, you know what, they're not going to result in blindness or kidney disease. But if on a regular basis, the diabetic allows their blood glucose to get too high, it causes high blood pressure because glucose is an osmolyte. It's in our blood and it tends to draw water towards it. It's a solute that influences osmosis. And so with these changes in blood pressure that are incurred by having high blood glucose, it can lead to damage to the capillaries all over our body. And this damage is gradual, a little bit here, a little bit there. We have these obviously we have capillary beds all over our body, but if you think about the retina of your eye, that's an incredibly delicate tissue. And as these capillaries are damaged over time, it can lead to the photoreceptors in your eye dying, and it can cause blindness. Kidney disease. You remember the glomeruli in the kidney, those capillary balls that are at the beginning of a nephron? Well, if you have elevated high blood pressure due to uncontrolled diabetes, those glomeruli, those vessels get destroyed a little bit over time, and you start to lose kidney function, which means your kidneys are not adequately removing waste from your blood, and you might end up on dialysis. Peripheral nerve damage in your hands and feet. So those capillaries get damaged, and the sensory neurons are no longer able to function due to a loss of oxygen and nutrient supply. That can lead you to have sores, cuts, abrasions that don't heal adequately because there's not enough functioning vasculature. And those sores can become infected, can become necrotic. And in order to limit the spread of that infection, parts of the body might need to be amputated. So it's pretty common for diabetics to lose toes, to lose feet, to lose their lower legs. And then, of course, damage to capillary beds in the heart and in the brain can dramatically increase the risk of heart disease and stroke. So most of these long-term complications of poorly managed diabetes are, again, they're caused by the hypertensive effects of higher than normal blood glucose, which leads to damage to these capillary beds. So in order to minimize the long-term risks for somebody who does have diabetes, the goal is to keep your blood glucose level within an acceptable range as often as possible. And so you have to do the work of your pancreas, or some of the work of your pancreas, where you think about the carbohydrate that's coming in across your GI tract. And you may or may not, depending on what type of diabetes you have, you may or may not need to administer the proper amount of insulin to control for that. Managing your weight and regular exercise are also key tools in managing one's blood glucose level on a daily basis. Our next endocrine topic is the ovaries. The ovaries are an endocrine structure. They are hormone-producing glands that occur as part of the female reproductive system. And the ovaries become active. They begin to secrete hormones at the onset of puberty, and this is in response to the new secretion of hormones from the anterior pituitary, FSH and LH, follicle stimulating hormone and luteinizing hormone. And so we've looked at a diagram like this previously when we talked about how hormones are controlled through homeostatic feedback mechanisms. So I hope you'll recall the relationship between the hypothalamus and the anterior pituitary. The hypothalamus releases GnRH, that's gonadotropin releasing hormone. And that GnRH travels through the hypophyseal portal system and influences cells in the anterior pituitary. In response to stimulation by GnRH, cells in the anterior pituitary will produce and secrete FSH and LH. And FSH and LH are broadly circulating hormones. They travel in the blood, and in the female reproductive system, their target tissue is the ovaries. And in response to FSH and LH, the ovaries increase their secretion of estrogens and progesterone. And as we discussed in the reproductive system, estrogens and progesterone control the events that occur in the uterus during the menstrual cycle. Estrogens have other effects, body-wide effects, that we'll talk about here. Estrogens, I use that word in the plural because there is no single signaling molecule called estrogen. So if you start talking about estrogen, somebody with a little knowledge on the topic will have to stop you and say, oh, well, which molecule are you talking about? Are you talking about estradiol? Are you talking about this other molecule? And so just to cover that base, I'll use the word in its plural form, and we'll talk about estrogens, a group of hormones. They're secreted by the ovaries and the adrenal glands. In the genetic female body, post-puberty, in the genetic female body, the major source of circulating estrogens is the ovaries, and in the male body, the major source of circulating estrogens is the adrenal cortex. And estrogens are responsible for the development of female secondary sex characteristics, which I'll talk about next, but essentially it's the changes that occur in the female body with puberty. Estrogens are responsible for the monthly changes that occur in the thickness of the endometrium with the reproductive cycle. And then lots of body tissues have receptors for estrogens, and estrogens play a role in bone metabolism, in connective tissue regeneration, and in regulating basal metabolism. So secondary sex characteristics are these traits that differ between males and females. And so we see two different species here that exhibit pretty dramatic secondary sex characteristics. It makes it very easy to distinguish male from female. So we're looking at a peahen and a peacock on the left there, where the female, the peahen, is rather drab in coloration, and she certainly does not engage in these dramatic behavioral displays like that peacock has these bright, numerous, heavy feathers and this brightly colored plumage, and he can elevate those feathers into this dramatic display, and he'll strut back and forth in order to curry favor with the female. And then on the right, we're looking at lions, and the lioness, the female lion, does not have a mane, and the male lion has this thick growth of hair on his head and his back and his chest. Those are secondary sex characteristics. And so what happens in our species? And of course, our species is enormously variable. So I'll talk about what happens in a typical female and a typical male. But does that characterize everybody? Absolutely not. So in a typical female, at the onset of puberty, so as this child is moving into adolescence and adulthood, these are characteristic changes. Her pelvis will get wider. She'll begin to develop pubic hair and axillary hair, where axillary refers to your armpit, or the junction between your upper limb and your torso. She'll develop breasts, and she'll change the way in which her body starts to deposit fat. So she'll accumulate fat in her hips, in her buttocks, in her thighs, and in her breasts. And as part of the reproductive system, we talked about the influence that estrogens as well as progesterone has on the monthly events that occur in the uterus, the thickening of the endometrium in expectation of an implanted embryo, and then how the decline, the monthly decline in estrogens and progesterone brings about her period. She begins to menstruate. Progesterone is also a hormone produced by the ovaries, and there's only one molecule called progesterone, so we don't need to talk about it in its plural form. And progesterone, I hope to remind you that in the ovary, the progesterone is produced by the corpus luteum, and that's that endocrine structure that forms in the ovary following ovulation, that's the word, following ovulation, that empty follicle, that ruptured follicle, is converted into the corpus luteum and it begins to secrete progesterone. Even in bodies that don't have ovaries, there are circulating molecules of progesterone, and the source of progesterone in the typical male body is the adrenal gland. And progesterone has more limited actions in the body compared to estrogens. Progesterone exerts its effects on largely the structures of the female reproductive system, and it is responsible for maintaining the thickness of the endometrium in preparation for an implanting embryo. And again, once that corpus luteum in the ovary degrades, circulating levels of progesterone will decline, and that's another trigger for the onset of menstruation. Menopause is an endocrine phenomenon. So menopause occurs at the end of the reproductive span of a woman's life. So she went through puberty and then her body was able to reproduce, and after menopause, her body is no longer naturally able to reproduce. And this is because the ovaries decline in function, so they decrease their production of estrogens and progesterone. And so the actions of these two hormones, estrogens and progesterone, will decline around the body. Her menstrual cycle will stop. We know that these hormones have multiple effects, primarily by studying menopause. What are the effects of estrogen? Oh, well, let's look at what happens when there's a lack of estrogen in the body, and it can bring about hot flashes, mood swings, an increased risk of heart disease, a loss of bone density, and the skin can become thinner and more fragile. In women who have lower than normal circulating levels of estrogen, or in women who are suffering from the side effects or the effects of menopause, sometimes hormone replacement therapy, or HRT, is prescribed. And this is a very low daily dose of estrogens. Sometimes it includes progesterone, and sometimes it also includes testosterone, which is another steroid hormone. We'll talk about that next. So this low dose of hormones is given on a daily basis with the goal of alleviating the effects of menopause. So mood swings and hot flashes might be made better or less severe by HRT. And then HRT has been shown to reduce the risks of osteoporosis. That's a loss of bone density that makes our bones more fragile and susceptible to fracture. HRT can reduce the risk of osteoporosis and heart disease. The testes. The testes are part of the typical male reproductive system, and similar to the ovaries, they become active at the onset of puberty, and they are influenced by the same hormones from the anterior pituitary, and those hormones are follicle stimulating hormone and luteinizing hormone. And the testes are the site of androgen production, and one of those androgens is testosterone. So there are several testosterone-like molecules. That a better term for characterizing these molecules is androgens. So androgens are produced by the testes and the adrenal glands. So in the typical adult male body, the major source of circulating testosterone or androgens are the testes. And then in the adult female body, we also have androgens circulating in our blood, and the major source of androgens are the adrenal glands. And androgens are responsible for the development of male secondary sex characteristics during puberty. They stimulate spermatogenesis in the testes. They influence libido, and that means our sex drive. And they are responsible for maintaining muscle mass as well as bone density. So the male secondary sex characteristics are things that occur in the body of a boy as he's going through puberty. And again, the span of human variation is great, and I am just talking about a typical boy going through puberty. It certainly doesn't happen in every boy going through puberty. So in a typical boy, There's a widening of the shoulders relative to the hips. Pubic hair will grow, armpit hair will grow, hair on the face and hair on the chest becomes thicker and denser. The larynx gets larger, so those vocal cords get longer, and they start to produce deeper, lower pitches. The genitals get larger, the penis and the testes get larger, and then there's an increase in muscle mass. So both the typical male body and the typical female body have circulating estrogens and androgens. What differs is the source of these hormones. So in a typical male adult, they have higher circulating levels of androgens than estrogens, but both are present in the blood. The major source of the androgens is the testes, and the major source of the estrogens is the adrenal glands. And almost the opposite is true in the typical adult female body. She has both circulating estrogens and androgens, but her circulating levels of estrogens is higher. And the source of those estrogens is the ovaries, and the source of those androgens is the adrenal glands. The adrenal glands sit on the superior aspect of each of your kidneys. And the adrenal glands have come up for us as part of the sympathetic nervous system, right? And in that context, we were talking specifically about the adrenal medulla. Here, we're talking about the adrenal cortex, or the superficial layer of the adrenal glands, as being the source of androgens and estrogens. And the hypothalamus and anterior pituitary gland, similarly to the ovaries, they control the testes. So the hypothalamus in the typical adult male body will secrete gonadotropin releasing hormone, that's GnRH, and that causes the anterior pituitary to secrete LH as well as FSH, which is not drawn in this diagram. And in response to LH and FSH, the testes increase their production of testosterone. And then notice those horizontal arrows in this diagram. Circulating levels of testosterone influence testosterone secretion through these negative feedback mechanisms. So a high circulating level of testosterone will feed back onto the testes, will feed back onto the anterior pituitary gland, and will feed back onto the hypothalamus. So in men who produce too little testosterone, androgen replacement therapy might be prescribed. So this is to augment their circulating levels of androgens. Our last topic is endocrine disruptors. And these are substances that occur outside the body. So they're exogenous. They make their way into our bodies, and they mimic hormones. They are structurally similar to a particular hormone, and because they're structurally similar, they're able to bind to receptors and activate those receptors. So they act typically as a hormone agonist. And in that way, they can interfere with one or more aspects of our physiology. And we find endocrine disruptors all over the place. Plants make molecules that are very similar to animal hormones. And when we eat enough of these particular plants, we can ingest these molecules that mimic hormones in our body. Pesticides and fertilizers and compounds that are used in the manufacturing of plastics. We find them in certain cosmetics and other industrial byproducts. So we'll do a couple of examples of endocrine disruptors. Probably the most infamous endocrine disruptor is DDT. DDT is a pesticide, and it was used in the United States starting in the 1930s. And it's a pesticide. It kills insects. And so it was seen as a boon, a windfall, something very beneficial for agriculture, right? So farmers grow crops, and they are sort of at a constant war with the insects that are trying to make their living on the crops. They eat the leaves, they eat the fruit, they cause damage to the crops, and so it's the farmer's goal to eliminate these pests. And back in the 1930s and 40s and 50s and 60s, DDT was this miracle substance that could increase agricultural yield because it killed the insects. And it kills the insects rather indiscriminately. It's not like it just kills the harmful insects. It kills all the insects and other creatures as well. And so in the 50s, 60s, and 70s, the evidence against DDT became overwhelming. It exerts harmful effects on lots of types of organisms. And probably the most famous harmful effects is how DDT interferes with reproduction in raptors, or these large predatory birds. So things like eagles and owls and hawks and falcons and osprey and condors. So these are large predatory birds. They're at the top of the food chain. They're carnivorous. So they're eating smaller animals. And a process known as biomagnification or bioaccumulation occurs. Let's just look at that bald eagle catching a fish. So it catches a fish, and that fish ate smaller fish. And those smaller fish ate zooplankton, these tiny microscopic animals that live in the water. And those zooplankton ate phytoplankton, these tiny microscopic algae-like plants that live in the water. And all of them contain DDT, because as DDT gets spread on agricultural fields, it makes its way everywhere in our environment. And so even the algae at the very base of the food pyramid, the algae have DDT. The zooplankton eat the algae. The zooplankton accumulate DDT in their tissues. The little fish eat the zooplankton. The little fish's tissues become full of DDT. The bigger fish eat lots and lots of little fish. And the bigger fish has this high accumulation of DDT in its muscle tissue and its fat tissue, actually, I think. And so when an eagle eats a big fish, it's getting a pretty big dose of DDT. And DDT is an endocrine disruptor. It turns out that DDT interferes with the reproductive system, and it makes these birds lay eggs that have very thin shells. So not the thick, sturdy shells that can withstand the weight of the parent bird sitting on them, right? That's what birds do. They lay eggs and then they sit on them to keep them warm. So in a bird that has ingested some quantity of DDT, they lay eggs with these very fragile shells. And so when the parent bird sits on these eggs, the eggs, they all break. And so reproduction essentially comes to a halt. And so in the 50s, 60s, and 70s, these large predatory bird populations, they were all on the brink of extinction. And these two birds here in particular, the California condor and the American bald eagle, that's like a symbol of this country, almost went extinct because of DDT. And so this book, Silent Spring, it's a very famous book, and maybe some of you have read it. It is known as having fomented the environmental movements in the United States. Part of the book involves cataloging the negative impacts of DDT spraying. It's sort of a compendium of the evidence against DDT and other things. And so for the first time, it was widely read. And so for the first time, just the general American public became aware of all of these threats to our environment. And it helped lead to a ban on the use of DDT in 1972. And so still, DDT is still found throughout the environment around the world. Even in places where DDT was never sprayed, we find these molecules. They are what are known as persistent. They don't degrade easily. They're out there, they're everywhere, they're still exerting their physiological effects on wildlife. And just as a crazy example, we have found DDT in the Arctic. There are no farms in the Arctic. We have found DDT in Himalayan glaciers. So these molecules, once they get into the environment, because of these biogeochemical cycles, they get spread everywhere. The good news is that because we've stopped using DDT And we have both protected and assisted lots of these large predatory bird species. Most of them have recovered, so they were on the brink of extinction. Now there is less DDT in their immediate environments, and they are laying eggs that have thicker shells, and these eggs are surviving and hatching. The American bald eagle is no longer on the endangered species list, and in fact, in some places, it's considered a pest. If you ever travel to the Pacific Northwest or parts of Western Canada, there are American bald eagles everywhere. Another example of an endocrine disruptor is BPA. BPA stands for bisphenol A. And BPA is an organic substance that is useful in the manufacturing of certain types of plastic. Very pliable, soft plastics include BPA. And we find these plastics lining cans, like you might buy a can of, what do you buy a can of? A can of corn or a can of spaghetti sauce, something like that. There's a thin plastic coating lining that can that might include BPA. And BPA is an endocrine disruptor. It binds to estrogen receptors and thyroid hormone receptors. And over the last several decades, there has been accumulating evidence of the harmful effects of BPA. And so in response to that accumulating evidence, the FDA has looked at, well, how much BPA can we put in these consumer products? And they have changed the rules. They have changed the safe limits. However, it's still not thoroughly understood and still up for scientific debate. It's still under study. How much BPA is a safe amount of BPA? There's no scientific consensus there. And because lots of tissues have receptors for estrogens and thyroid hormones, lots of tissues are potentially susceptible to harmful effects or endocrine disrupting effects of BPA. And unfortunately, it seems like infants and children are more vulnerable to the effects of BPA than adults. And there is some evidence to support the idea that BPA can impair brain development and cause behavioral problems in children. And of course, that can carry into adulthood. And it may play a role in depression and drug abuse. We're not sure. It's still under investigation. And so in response to these multi-pronged, multifaceted avenues of investigation that lead to evidence, the FDA has changed the rules for including BPA in consumer products, particularly products that are intended for children. So beginning about 15 years ago, you started to see these stickers on plastic products, BPA free, so that you knew that those plastic baby bottles that you were buying or the plastic water bottles that you were buying did not include BPA. And I think the general public no longer needs to be told that they're BPA free because they're all BPA free at this point. And that brings us to the end of the endocrine system. This is a summary of the topics that we have covered in segment 1 and in segment 2. Thank you for watching.